Here's the trap we've all been trained into. Most musculoskeletal education, chiropractic, physiotherapy, osteopathy, sports medicine, etc., teaches us to look for structural causes. And structural causes are real. Pelvic alignment matters, tendon low capacity matters, joint drain matters, but we were not trained to ask the deeper question. If a glute is weak, why is it weak? If the performance is tight, what is it bracing against? If the tendon keeps getting irritated, what is failing to absorb load further up the chain? In our training, the answer usually stops at the structural level. The glute is weak because it has been deconditioned. The piriformis muscle is tight because of poor posture or repetitive sitting. The tendon is irritated because the patient runs too much. All of those answers are partially true, and all of them miss the upstream signal. Here's what I want you to consider. When you find a weak glute in clinic, you're running manual muscle tests on the patients whose nervous system has been compensating around the muscle for weeks, months, or years. What you are calling weakness is in many cases not true weakness. The muscle has contractile machinery to do the job. Anatomically, it's intact. What has happened is that the nervous system has turned the volume down. Reflex inhibition, neurological gating, some physiological phenomena you read about in the ACL literature, where the quadriceps muscle measurably loses voluntary activation after knee injury, even though the muscle itself is structurally fine. When you treat the weak glute with progressive loading, you are loading a muscle the nervous system has actively turned down. You can sometimes drag it out or output up by sheer effort, but the moment the load stops, the inhibition reasserts itself. And 4 weeks later, the patient is back. Same logic applies to the tight piriformis. The piriformis is not the problem. The piriformis is bracing. Bracing against what, you ask? Against an inhibition, a deep stabilizer inhibition, very often on the opposite side, that the body is trying to compensate around. You release the piriformis, it tightens up again. Of course it does. You have treated the splinter, not the wound. I'm not asking you to abandon structural thinking. Structural thinking is essential, but it's one floor of a 2-floor building, and most of us has been taught to live on the ground floor. The neurological floor sits underneath everything we see in clinic. Until we walk downstairs, we will keep treating compensation and watching them return. So the question becomes, how do you find the upstream signal? How do you tell in front of the patient in real time which muscle the nervous system is currently inhibiting? This is what the next slide is for, because the answer is not imaging and it's not palpation. The answer is testing.